using emollients, using keratinolytics makes some sense in managing our patients. We just have not talked a lot about it. And that was really the premise and the basis of this consensus paper.
Welcome to the Learn Skin podcast with me, Dr. Raja.
And me, Dr. Hadar, where we discuss all things skin.
Join us as we delve into the art and science of skin health in today's episode.
Hey, Raja, can you say the thing I told you to tell them?
Of course. We are board-certified dermatologists. This podcast is meant for educational and informational purposes only and is not considered medical advice, nor does it serve as a substitute for professional care by a doctor or other qualified medical professional. All opinions shared do not express the views of Learn Health, Inc. Let's get to the good stuff.
Hey, Raja, how are you today?
Hadar, I am doing pretty well, my friend. But I've just been thinking more and more about psoriasis. It's been a while since we've talked about that, hasn't it?
I agree. Psoriasis, that scaly rash that we all see in clinic day in, day out, it's almost like chapter 1 in dermatology, psoriasis. And, since the advent of biologics, it almost seems like a passé kind of topic to discuss, but actually there's constant innovation and there are still very challenging patients. And so, we thought, who can we bring here that can really put life into psoriasis? Because, we still see it day in, day out. It's still bothering our patients and there's still unmet needs. And I think we came up with the perfect guest. You want to introduce him?
Yes, we did. And in fact, with psoriasis, there are so many treatments, but at the end of the day, it's still an art on how to put it all together. And so we have Dr. Brad Glick. He's a board-certified dermatologist. He is pretty eclectic, I would say a modern-day Renaissance man in many ways, because he practices at his private practice, which is the Glick Skin Institute in Florida. But he's also on the faculty at the dermatology department at the Herbert Wertheim College of Medicine at Florida International University, and dermatology residency program director at the Larkin Palm Springs Hospital. And not only that, I just met him while he was helping to run the National Psoriasis Foundation meeting that was just unlocking all these new thoughts and lectures for residents and rheumatology fellows. So Brad, welcome to the podcast. We're super excited to talk psoriasis with you.
Well, I'm excited to be here. And my God, man, you make me sound so good. I'm excited to hear myself. But thanks for having me.
Can we kick things off by just saying, first of all, you've got this career that is pretty diverse. And I got to say, you must live a pretty fun-packed life every single week to week. But how did you find yourself in dermatology? And what got you interested in psoriasis to the level that you're interested in? Because clearly you're organizing meetings and whatnot. So can you just tell us a little bit about the journey there?
It's a great question. And actually, it's a very interesting journey. When I was in medical school, my best friend in medical school wanted to go into physiatry. So he advised me to do a rotation at the Rehab Institute of Chicago attached to Northwestern. And while I was there, I was on a combo physiatry and rheumatology rotation. And I kind of snuck off more with the rheumatology folks. And the rheumatology folks kind of had opportunities to call dermatologists because they needed biopsies and they needed dermatologist opinion. And so I ended up running around with a Dr. Fred Levitt, who ironically, we don't have enough time for this, he actually was a mentor for my practice partner, ironically, because my practice partner trained at Northwestern. Anyway, I was so fascinated by some of these skin conditions, seeing cutaneous lupus, seeing the associated arthritic conditions. And so I immediately scheduled a dermatology rotation. And really, Raj, Hadar, the rest is history.
Absolutely. And I think it's really fascinating career that you are having because everywhere I go, your name pops up. I mean, I think we couldn't go through your entire CV, but I think it is important to mention that you're serving diligently on the board of directors for the American Academy of Dermatology. And if we have some time, maybe we'll touch on some leadership and how to inspire our next generation of leaders, because I think it's such a great job that all of you guys doing there on the board of directors. Well, with that in mind, let's talk psoriasis because, hey, Brad, what's new?
Well, there's a lot of things that's new. I think what's just a new commentary is just that we have so much in the toolbox and we have a lot of different options for the different presentations of psoriasis, which is pretty heterogeneous. We still have pills, we have new therapies, TYK2 inhibitor, we have some amazing new topical therapies for limited disease, or at least from a practical standpoint, for adding on to when patients are not completely successfully resolved from their psoriatic disease. For instance, we have biologic therapies that 60 to 70% of the time can clear the skin. But what about the other 30 to 40% of the time where we can't? But because we have so many novel therapies, we can add in oral PD4 inhibitors. As I just said, we have a TYK2 inhibitor. If there's limited residual disease, we have a topical air hydrocarbon receptor agonist, a topical PD4 inhibitor. We've really come a very long way. Some of what we were mentioning before we came on this evening was that just is simply that, but that's not everything. There's other approaches that we need to take, much like we think of in atopic dermatitis and, let's say, restructuring the skin barrier. We need to do that in the setting of plaque psoriasis as well. I would also say, not to jump around too much, that even though we're kind of a little further along in the wave of psoriatic therapies, there's still some others that are coming. Bimekizumab has been waiting there on our plate to be utilized, to be approved by the FDA, which is an IL-17A and F inhibitor. That's very exciting. It has pretty historic data in terms of PASI responses. It even has some remarkable ACR 20 and 50 responses like we've never seen before. Hopefully we'll get that in our toolbox. But there are some other IL-17 blockers that are coming, an antibody that likely will come. Another TYK2 inhibitor will come. And so there are some unique therapies. We're very fortunate for our psoriasis patients that when one therapy doesn't work, we certainly have an opportunity to choose another therapy. And I think, as we may talk about, combination therapy, at least for me, is where it's at.
Oh my gosh, there's so many options for psoriasis now that, I feel like this was the origin of just all of the biologics in the dermatology space. It seemed to be the thing that we all talked about. Now you have all these medications. But you know what's really interesting, Brad, that I noticed in a publication that you were a part of pretty recently, and I thought we could touch on this because it's not something that we talk about much, but psoriasis and skin barrier dysfunction. And you were part of a publication that was titled The Role of Gentle Cleansers and Moisturizers in Treating Psoriasis. Now, that is such a unique take that we don't talk about, because you even pointed out when you look at PubMed and skin barrier and atopic derm, there's like thousands of articles. Whereas for psoriasis, not something we talk about much. So could you talk to us a little bit about that? What is it that we should know about the skin barrier when it comes to psoriasis?
Well, it's interesting that I think if we go a little bit back to our training, and I think all three of us agree with this, that when we think of atopic dermatitis, that heterogeneous disease, probably a little bit more heterogeneous than psoriasis, it's skin barrier. Of course, now we know inflammatory cytokines, outside in hypothesis, inside out hypothesis. But what about psoriasis? And I think the way that we're trained is we really don't talk very much about the restoration of the skin barrier in what, in some respects, is similarly a red, scaly eruption, kind of like Hadar started with today with our pink, silvery, scaly plaques of psoriasis. Now, clearly, the plaques are often a little bit thicker. They're a little bit more difficult to treat. But to your point, we really don't talk about it a lot. And in our paper that we just published in the JDD, one of the rationales for this was simply because while we have all these amazing therapeutics that we just talked about, oral systemics, biologic systemics, some amazing topicals, new ones that even in them themselves may restructure a skin barrier, just like tapinarof, what may do in atopic dermatitis. What about the barrier in psoriasis? And so we sat around as a group, a consensus group, and looked at 15 statements that really questioned the role of the skin barrier in psoriasis. And there's not a lot of data. There's not a lot of scientific data. And from a therapeutic perspective, in terms of repairing the data, when we did a PubMed search from over about 10 years, we came up with 41 articles in total that kind of fit the bill, if you will, of psoriasis and skin barrier, or psoriasis and skin barrier dysfunction. And so there's not a lot out there. So what we chose to do was come up with 5 really clear statements as to how we would move forward in terms of further investigating the skin barrier. And so we came up with 5 very specific statements acknowledging that psoriasis is an inflammatory skin disease and that there are other inflammatory disorders where there's skin barrier dysfunction, hence atopic dermatitis. But in psoriasis, that kind of cause and effect relationship isn't quite as well understood. What we do know is that it's probably deficiency of ceramides that is probably the biggest issue in skin barrier dysfunction in psoriasis. And it's not completely surprising because even though we know that it's a disorder of keratinocytes that's driven by inflammation and cytokines and what have you, the issue is that it really is a disorder of the keratinocyte. And wherever that disorder is, whether it's in the stratum granulosum or the stratum spinosum on a scientific level, we have this fractured barrier. And from a commonsensical standpoint, using emollients, using keratinolytics makes some sense in managing our patients, but we just have not talked a lot about it. And that was really the premise and the basis of this consensus paper.
That opens up so many different thinking channels for me. But I do know, for example, that some of my patients come in and say, they use some emollients, because some of them don't even know what they have, or they ran out of medications. That's what they use in the meantime. It seemed to help them. Of course, it doesn't resolve someone who's very severe, but they definitely see benefit in that. So it makes perfect sense. And the other thought I had was about the issue of itch. For a long time, itch was not mentioned when you manage psoriasis. I think that now is changing as we just learn more about itch in general. Do you think that that plays a role in why some patients with psoriasis are so itchy?
I do. I think it's an exceptional parallel. And let me give you an example just from my thought processes. If you look at some recent data on one of our newer therapeutics, which is a PDE4 inhibitor topically, and when you look at the inflammatory changes, for instance, in the intertriginous folds, they measured itch. In the data for skin disease on the body, we saw very small placebo responses, vehicle responses, I should say. In the intertriginous folds, as one example, we saw not only significant improvement in the investigator's global assessment for intertriginous folds, gentlemen, but what we also saw was a dramatic, and I mean dramatic, reduction in itch. But what we also saw was a vehicle response. So what I glean from that is two things, and it's a very interesting parallel, Hadar, and that is that I think when you restructure the barrier, even in psoriasis, you get reduction in itch. And there is some data that looks at not only add-on therapy from various emollients, whether it's linoleic acid, whether it's combinations of salicylic acid, urea, and other humectants, but not only can they be adjunctive emollients or barrier restoring interventions, but they may actually help us maintain the barrier more long term in periods of quiescence. And so I do liken this to your point because I just briefly mentioned that one particular study because the vehicle response was high. But I think the vehicle response is high because it parallels the marked improvement of itch because I believe, and this is just my opinion, that in restoring the skin barrier, we have some downregulation of some of those markers that are responsible for the itch that we see in conditions like psoriasis.
Brad, I mean, when you think about psoriasis and you just think about the massive turnover that occurs with these cells, I mean, normally it takes 2 weeks to get up to the stratum corneum, and in psoriasis, it's like 3 days. Just thinking back to my engineering days when we used to do a lot of work on skin barrier and transepidermal water loss, it only makes sense that it's a big barrier issue with psoriasis. How can you form a normal barrier when you can't even have time to mature the cells properly? They're just going at the speed of light. So I totally feel the same way you do, which is that you have this barrier problem. And I think the itch has been underappreciated for psoriasis just because we've focused on it so much in atopic derm. But a lot of these newer studies are coming out showing that the itch is a big deal in psoriasis along with pain. But I think your point on the vehicle is really well taken. I think in the end, it is addressing one of those core symptoms that bothers people with psoriasis. So I appreciate you bringing this up and talking about it.
I would add in that the only difference, even though from a commonsensical perspective, would say you've got two itchy scaly rashes. We'll use the atopic dermatitis model versus psoriasis model. But the difference is, as you describe with that rapid turnover, we're going to see these really thick, silvery, scaly plaques, very different than the fractured skin barrier of atopic dermatitis. We wouldn't necessarily use a salicylic acid or a urea on someone with really cracked, burdensome atopic skin. But I think in psoriasis, various combinations of salicylic acid, urea, other humectants used first to kind of take down that hyperkeratosis, to take down that hyperproliferative
Right.
effect that you just described, and then follow with the same types of emollients that we use in a condition like atopic dermatitis, not only makes sense from a clinical perspective, but there's limited data that supports this. The problem is the studies are very small, 30, 60 subjects. Maybe the biggest in our consensus group when we reviewed the data was 178 patients.
Wow. Well, folks, if you're listening to us, this is what happens when you speak to Brad or any other expert, but someone who's a master in his field, because we came into this conversation trying to take all the treatment in psoriasis and trying to make it simple, but I just got hit with a barrage of new treatments and new ideas, things I didn't even think about. So
Time
thank
to
you very
learn your
much for this.
moisturizers, Hadar. Time to learn your moisturizers, my friend.
I know, I know. Who would have thought, right? And so, Brad, I actually want to ask you because I think you're such an expert in psoriasis and seeing a lot of patients. So I want to take it one step to the basic because now that we have so many treatments, one of the challenges I find sometimes is how do you introduce this to patients in a way that they understand what we're talking about? Because you just mentioned so many different mechanisms of action, and the biologics just in general is so complex, and there's a lot of fear about immune suppression. And so taking all that and then trying to introduce all the modalities of treatment, all the mechanisms, and all the subtleties that are there, and trying to wrap this up in a palatable kind of spiel to patients when you have 15 minutes or so, right? And, let's take the average patient. I mean, I know it's very different to distribution, the type of psoriasis you see. I know that, but just let's assume for the sake of conversation, this is a patient that requires systemic therapy. Do you have kind of a go-to spiel that our listeners, I'm sure, are thirsty to hear?
I simplify it. I tell the patients that specifically in psoriasis, but many of our skin diseases, the red skin is reflective of substances, targets. I'll even use the word protein sometimes that are responsible for that inflammation in your skin. And what we've learned over the last 30, 40 years is that we have molecules, we have agents, medicines that we can use to specifically target those particular substances that are responsible for the redness. And, I talked to them a little bit about what I like to call the cytokine soup. I mean, I put it in a little bit more bland terms, but I use the redness in the skin as a definition of targets for all of these different drugs. Hadar and Raj, the thing is right now, patients have really become a lot smarter. I think DCC helps them, education, social media. Our patients are coming in and they're kind of equipped having a little bit more knowledge than maybe they did, when we were at the beginning
Yeah,
of the
that's a good
systemic
point.
therapy and biologic era. So it does make it a little bit easier. But to your point, and I have to say this, I'm at the podium at the MPF resident and fellow meeting, and I'm standing on the podium next to Andy Blavelt, and he turns to me and he asks me a random question. He says, Brad, what's the number one question that the patients ask me? And it's really kind of two questions that ended up being the correct answer. And one is, what's the best of all these therapies? And the second one is, how do I pick them all? And it's really to your point, Hadar, about we have so many. How do you explain it? And how do you get to the one that's best for the patient? And when they're naive to systemic therapies, that's a whole nother discussion too. But I think we've advanced so much. And I think it's the patient's understanding of even the fact that injectables now can remit cancer completely. They've gotten used to learning about the fact that migraines, which are terrible, patients can get shots and the migraines go away and they can be controlled. So I think they're getting a little bit more used to this. But back to principles, I still tell them that red skin reflects substances that live inside your body that we can actually improve. We can decrease them. We can decrease them and the redness gets better, your skin gets better, and it can really improve your overall health. And quite frankly, I talk to them about the larger potential benefits that we believe that some of these patients do get from, for instance, biologics like, let's say, TNF inhibitors and IL-17 inhibitors with their anti-atherogenic effects. But you can simplify it, and that's one of my ways.
One thing I wanted to touch with you is about kind of the breakthrough disease, right? So you get patients and you start them on systemic therapy. And let's take someone who's moderate to severe. And let's say you started one of the biologics and they're doing kind of great, but then there's still some residual disease and you can't really completely clear them. How often does that happen to you, and what is your strategy and thinking about those patients?
Yeah, it's such a great question because 40, 50, 60% of the times I alluded to in the beginning when we kind of launched this discussion and talked about this loaded toolbox we have, if you think about it, the most successful therapy we have right now, which is an IL-23 inhibitor, at least on paper, clears patients, let's say up to about 60% of the time. 40% of the time, they don't. And so there's a pretty good number of patients, gentlemen, that come in and they need other things. And if someone's really doing very well, they're 75% better, 80, 90% better, I have to come up with some other strategies to add to their therapy. And so I think adjunctive therapy, combination therapy is really an everyday thing. If someone's completely clear and that happens 60% of the time, we're thrilled. The interesting thing for me, what we've done traditionally with limited plaque, someone who's 95% clears, and they have some residual areas in their scalp or their elbows, we might do intralesional corticosteroids. We have wonderful topical corticoids. We've cycled topical corticoids and vitamin D over the years. We have fixed combination therapies in topical vitamin D and beta-methasone dipropionate. We have halobetasol and topical tazarotene in a fixed combination. We can add these in and get really nice, successful response to kind of take a little bit of the burden off of the biologics, as I like to say to my patients, and then get them to clear by using topical therapies. But I'll take it one step further. For me, what's exciting right now, and not that this is something I'm particularly promoting, but I think it is very true that with using corticosteroids over many years, and they're still highly effective therapies, we still get into that sawtooth pattern. Even if you're putting patients on these therapies like clobetasol and beta-methasone dipropionate as corticosteroids, you have limitations into the time frame that you're going to use them, even if they're, for instance, in bony prominences with pre-hyperkeratotic plaques. What I'm intrigued by is perhaps a slight shift in our topical therapeutic paradigm across all spectrums of disease, but particularly in the setting that you've described, where we can add in, for instance, a topical tapinarof, an arrow-hydrocarbon receptor agonist, or a topical PDE4 inhibitor or rofumilast, and to be even broad, even TCIs at times, depending on the locations of topical calcineurin inhibitors, and be able to treat to complete, to have something to really get after those residual lesions. And that's one area that I've really been looking at very carefully lately. But some patients, even when you add in all the topicals in the world, they get so much better, but they don't clear. And we're all a little spoiled right now. I think we're spoiled. We've got great drugs in the toolbox, and the patients as well have higher expectations of our care, particularly in psoriatic disease. So what I've done a lot of lately is to try to be savvy by adding in some oral systemics. I still use some methotrexate. I think it's a great addition to TNF inhibitors. And
Yeah, I agree, Brad. I do the same thing, and actually, that brings up a question I wanted to ask you. We talk about psoriasis, but what about when you start seeing arthritis? Do you tend to refer that to the rheumatologist, or do you tend to try to take care of that with some respect with the tools that we have? Because I see expansion into approvals for psoriatic arthritis now in many of our medications that we're commonly using for cutaneous disease.
Yeah, it's such a great question, and a segue from Hadar's commentary, not only about combo therapy, topicals, and other systemics, and when to add in, but yeah, what about when they have joint pain? It's so interesting coming out of this National Psoriasis Foundation meeting. We talk so much about this and so much about combination therapy, and of course, with having rheumatology fellows in the room, we talked a ton about psoriatic disease, with the number one comorbidity 30% of the time or more being psoriatic arthritis. It does change the picture. I mean, I will say for the audience, we screen at every visit. We use the psoriasis epidemiology surveillance to the PES score. It's 5 questions that are asked. 3 out of 5 are positive, and they generally on the realm of, do you have joint pain? Have you ever had a swollen joint? Do you have heel pain, etc.? And if 3 out of 5 are positive, then, there's suspicion for psoriatic arthritis. And I think it does create a whole different story. Clearly, systemic therapy is necessary. I think we're loaded with great therapies in the toolbox. For me and for many of my other colleagues, let's say close to about 35% of dermatologists are prescribing biologics for patients with psoriatic disease. So I think we can be dermatorheumatologists, but I think it depends on severity. And, we certainly want to have a patient on the right therapy. We certainly want patients on therapeutics where we are potentially, at least on paper, preventing inhibition, if you will, of radiographic progression of disease. Those particular therapeutics are important. But I believe the advancement in biologics, gentlemen, have allowed us to really be that dermatologist. And I will reach out to my rheumatology colleagues when I'm using an agent, when I suspect or feel that I clearly have psoriatic arthritis, if I see dactylitis, enthesitis, nail pitting, scalp psoriasis, where patients are 4 times more likely to be having psoriatic arthritis compared to those that don't have scalp psoriasis. And so usually I'm on the right track, whether it's a TNF inhibitor or a 17 blocker, and to a lesser degree our interleukin 23 blockers. But when I have patients on therapy for about 4 to 6 months and they're not turning around, it's time to make the phone call. There are some patients that, I see that they're more advanced at the time of diagnosis, or I'm seeing and then I'm the 4th or 5th dermatologist, and maybe they've never seen a rheumatologist. That's the time I'm going to call out from my rheumatology posse. And I'm so fortunate in my region because I have about 4 or 5 that I can literally text or call and I can get them in there, because patients complain it's tough to get into a dermatologist. It's pretty tough to get into the rheumatologist as well.
Oh my gosh. It is so tough to get into
That's so
rheumatology.
true.
I have to say, Brad, I appreciate, it's actually very heartwarming to hear about us talking about psoriatic arthritis from a dermatologist perspective. And I can just say personally, I see a lot of, in our practice, we like almost 60, 70% Medicaid with in California, Medi-Cal. Getting to a rheumatologist is, it's going to take months. So many of us will just take on the rheumatological condition. I actually think dermatologists should feel more comfortable doing so because it is part of the dermatology condition. It was a funny thing. I actually asked some rheumatologists, how do you diagnose psoriasis and psoriatic arthritis? They said, we wait for you to diagnose the psoriasis and then we call it psoriatic arthritis. So many times we'll be in the front row seat to call it psoriatic arthritis. But I appreciate your point that at least now we have tools. And I want to do a shout out to what Brad just said. He talked about the PEST tool, which is the Psoriasis Epidemiology Screening Tool. You can easily find this on the National Psoriasis Foundation website. It's at psoriasis.org/psoriatic-arthritis-screening-test. Very easy to find. You can pull it up in the room if you really need to. Simple 5 questions so that you don't overlook this very important comorbidity. Appreciate you bringing that to our forefront here, Brad.
Sure.
Absolutely. And I think with that, I would like to just take a moment to thank you, Brad, for everything that you do. I know your residents rave about your teaching, and so I was able to get one more piece from your CV into this. And thank you for your leadership and everything that you do and your expertise. And I'm 100% sure that we will hear more from you in upcoming episodes of this podcast, because we just literally scratched the surface of this episode.
Well done,
thank
Hadar.
you very much. Thank you.
Well, thank you both. It's an honor. It's a privilege. I'm humbled. And I like to close by saying we really are blessed to be dermatologists. It's the most amazing specialty.
Oh, it's the most amazing specialty. Hey, listeners, we want to share some great news with you. Over the last year, we have been reviewing and redesigning the successful Integrative Skin Health series. Newly named Dermatology Clinical and Integrative Essentials, or DCIE, a team of incredible integrative dermatology experts have been working on a new and improved curriculum focused on common patient questions and concerns. We're excited to launch the new DCIE program on January 1st, 2024. And right now, through November 30th, you can save $200 off the regular price when you sign up during our pre-sale. But that's not all. You also get immediate access to the original program, the Integrative Skin Health series. So it's like getting 2 programs in one.
What's really great about this program is that it's geared towards PAs, NPs, MDs, and other healthcare professionals who are new to the profession or seasoned veterans, because, evidence-based integrative approaches are still emerging for all of us.